Hello everyone. Welcome to Unacademy. Let's crack NEET. I'm Dr. Shilpa Dinesh. I'm a practicing pediatric consultant and an educator in Unacademy. I have an experience of teaching undergraduate and postgraduate medical students, and I have done my MBBS and MD from Rajiv Gandhi University of Health Sciences. So today we'll be discussing about protozoal infections. So malaria, mebiasis, leishmaniasis, and giardiasis. Okay, so this is today's topic of discussion. Before that, I would want to talk a little bit about Unacademy. Unacademy is India's largest online learning platform, and there are a lot of benefits you can avail from this platform. Firstly, the daily live classes. Okay, so there are regular classes happening in this platform, and you can attend your favorite educators class and engage in discussion and ask your doubts, and doubts will be cleared and the answered in the live chat box immediately. Okay, also whenever you're preparing for your entrance exam, you need to have a structured course. You need to plan well for your preparation. So you need to revise well ahead for your exam, right? So here in this platform, all our courses are structured in line with your exam syllabus, and this will be of a huge boost for your preparation. Also, coming to the live tests and quizzes. So once you start preparing for your entrance exam, you need to evaluate yourself. You need to evaluate what is your strong area, what is your weak area, right? So that is done only with quizzes and tests. So here in Unacademy, there are a lot of live, and as a result, you will be able to analyze yourself better, and you will be able to concentrate on your weaker subjects. Also, coming to the unlimited access. So once you subscribe to the subscription, you get access to all the classes on the subscription platform. So even if you have missed the live class, you can go back and watch the recorded class again and again. So all this in the comfort of your home, in the comfort of your own device. So I would highly recommend this platform, and using this platform from the beginning part of your preparation will take you a long way. Okay, so these are the top educators, and they have regular classes in this platform, and all the 19 subjects required for your NEET PG preparation are taught in this platform. Okay, and now these are the ongoing courses in our platform right now. And coming to the subscription, so you can see here the subscription package varies from 1 month to 2 years. So I would suggest the 6 month or the 1 year for the students who are preparing for their 2021 NEET PG, and for the interns and the final year students, the 12-month and the 2 year subscription would be very helpful. Okay, so the 6 months course will cost you around 20,000, and using my code Shilpa 10, you'll get a 10% discount, and it'll come up to 18,000. For the 1 year subscription, it will cost you 25,000, but using my code Shilpa 10, you'll get a 10% discount, and it'll come up to 22,500. And the 2 year subscription, which is 30,000, and using my code Shilpa 10, you get a 10% discount, and it'll come up to 27,000. So the prices are very reasonable compared to the other platform. And once you subscribe, you just not get, you'll get access to all other educators as well, just not mine. So you get access to all the other classes. Okay. Okay, so coming to today's topic. First topic we'll be discussing is the malaria. Okay, so malaria is a very important protozoal disease, and the genus of the protozoa is Plasmodium. Okay, and the four species are Plasmodium vivax, Plasmodium falciparum, Plasmodium ovale, and Plasmodium malariae, right? So this is a very important disease, and it's in a under the national vector disease control program. Also malaria comes under this. Okay, so now when it comes to the transmission, what is the infectious stage of the parasite? So the infectious stage of the parasite is the sporozoite. Okay, so now this sporozoite is transmitted to the humans by the bite of the female Anopheles mosquito. right? So now in this, the Anopheles mosquito, there are 6 species of Anopheles mosquito. So you should know, one is the Anopheles culissifacis. Then there is Anopheles fluviatilis. Then there is Anopheles stephensi. Then there is Anopheles minimus. Then there is Anopheles philippinensis. And then there is Anopheles sandicus. Okay. So each of these species might live in a different kind of water environments. Okay, so that is why this the knowing the species is very important. So now coming to the life cycle of the parasite. So first of all, you should know in the humans, the life cycle is divided into the hepatic phase or the tissue phase. Then it is the erythrocytic phase. Then there is the gametocytic phase. And next is the exoerythrocytic phase, right? Yeah. So now what happens in the hepatic phase? So now, as I've told you, the mosquito transmits the sporozoids into the humans with the mosquito bite, right? So this sporozoids enters the hepatic. So you can see over here the sporozoids entering the liver, right? So once they enter the liver, they infect the hepatocytes, and in the hepatocytes they will multiply further. So you can see there is a lot of multiplication happening, and when a lot of multiplication happens, there will be the rupture of the schizon, and there will be release of merozoites. Okay, so these green ones are called merozoites. So this merozoites, when it comes to the vivax, Plasmodium vivax, around 2000 to 15,000 merozoites are released. But when it is in Falciparum, around 4,000 merozoites are released. Okay, so once these merozoites are released, what happens? So they go and invade the erythrocytes. Okay, so now until this was the hepatic phase. So the hepatic phase is the asymptomatic phase, and it corresponds to the incubation period. So the incubation period will be approximately 10 days, so 1 to 2 weeks, right? So this is the hepatic phase. So now once the hepatic phase has been passed, now the merozoites have come to the bloodstream, so they'll start to infect the erythrocyte, right? So as you can see, they're infecting the erythrocytes. So in the erythrocytes, these merozoites will further transform to trophozoites. Okay, so the trophozoites are transformed how? So trophozoites, there are two trophozoites. One is the early trophozoite and the other is the mature trophozoite. So the early trophozoite is the ring forms. Okay, so they are the ring forms. And then they further become the mature trophozoite, that is the late trophozoites. Okay, so now what happens is this trophozoites will further multiply and they become the multinucleated schizont. This is the multinucleated schizont. Okay, so this multinucleated schizont further again ruptures and then will release merozoites. So again what happens is further release of merozoites. So there is a cycle happening. The merozoites further go on infecting the erythrocytes, right? So this is how the clinical features present. So the patients at this stage will have high grade fever, they will have chills and rigors, right? So this is when in this stage the symptoms present. So symptoms present in the erythrocytic phase. Okay, so now in what happens in falciparum is the falciparum has a feature of cytoadherence. Falciparum has a feature called as cytoadherence. So this cytoadherence of the falciparum, the falciparum, as a result, in case of a falciparum infection, these abnormal cells, erythrocytes, won't go to the spleen to be what is it? The spleen generally destroys the abnormal erythrocyte. So the spleen doesn't destroy because the abnormal erythrocyte are not going to the spleen because of the cytoadherence. Okay, so this is how in case of falciparum, because of this, the features in falciparum are more severe, and the chances of falciparum infection going to severe and or complicated malaria is high. Okay, so now coming to the gametocytic phase. So in the gametocytic phase, what happened? Some of the merozoites will get converted to gametocytes. Okay, and then there is over here what happens, this doesn't cause any new symptoms in the gametocytic phase. What does the gametocytes do? The gametocytes are taken up by the mosquitoes in the next bite. Okay, so this gametocyte enters the mosquito in the bite, and this is very crucial for the development of the this thing, the zygotes in the mosquito. Okay, so next comes the exoerythrocytic phase. So in the exoerythrocytic phase, what happens? So in the okay, so it is divided as cold stage, hot stage, and the sweating stage. So in cold stage, what happens? So the cold, the patient feels cold. There is chills and rigors. Okay, there is chills and rigors. Okay, so this is so based on the symptoms, malaria is divided into severe or complicated malaria and uncomplicated malaria. This you need to remember, because the treatment is different for the severe or complicated malaria, and the management for uncomplicated malaria is different. Okay, so now coming to the what are the criteria for severe malaria. So first of all, there will be the clinical findings are if there is an impaired consciousness. So if the child is so lethargic, or is in a state of coma, the child is not arousable. So that is one important thing. Prostration, the child is unable to walk. This child is so weak that you have to lift the child. Okay, so prostration, the child is not able to take anything orally. There is failure to feed. Multiple convulsions. What does multiple convulsions feel? More than two convulsion in 24 hours. Okay, next, there is deep breathing, respiratory distress. There could be acidotic breathing, right? So that is the next one. Fine. Next is the circulatory collapse or shock. So when the blood pressure is, the systolic blood pressure is less than 70. Okay, in adults it is 70, and when children, when the systolic blood pressure is less than 50. Okay, next, presence of, so now what is presence of jaundice? What does it indicate? So when there is jaundice, that means there is some kind of hepatic dysfunction happening. So presence of jaundice is again a feature of severe malaria. Hemoglobinuria, abnormal spontaneous bleeding, pulmonary edema. So these are all the clinical findings which correlate for a severe malaria. So if any one of this is present, and if there is presence of asexual parasitemia, then you have to include this under severe malaria. So what are the lab findings in a severe malaria? So if there is hypoglycemia, if there is metabolic acidosis, if there is severe anemia, the hemoglobin is less than 5. Hypoglycemia if the sugars are less than 40. Okay, hyperparasitemia, hyperlactemia. Okay, if the lactate levels are more than 5 moles per liter, and if there is renal impairment, that is the serum creatinine serum creatinine is more than 3. Okay, so this is how you diagnose severe malaria. So now how do we diagnose these children with malaria? So diagnosis main thing is very important is the microscopy. So specific diagnosis. So the gold standard for the diagnosis of malaria is examination of a thick film. Okay, examination of a thick film. So in the thick film, okay, you will be able to detect up to 5 to 10 parasites per microliter. So now what if it is a thin film? Thin film doesn't have a very good sensitivity. Okay, so thin film doesn't have a good sensitivity, but because in the thin film you will be able to identify species, so species identification can be done. Okay, another thing is this gives you a microscopy of this gives you a idea of parasite load when you do a film examination, parasite load. Okay, and it will help you in the prognosis. So prognosis with the mature schizont or a pigmented neutrophils is a bad prognosis. So bad prognosis is what? If there is mature schizonts and pigmented neutrophils. So pigmented neutrophils, mature schizons are bad prognosis. So when you examine a film, if you have mature schizons or pigmented neutrophils, it gives you bad prognosis. Another thing is it helps you to track the response for of treatment. Okay, so this is why examining the film is very important. Okay, another thing is so what happens is when you get a peripheral smear done, if the patient has already received partial partial malaria treatment, that time it is very difficult to get a confirmed diagnosis. Okay, so sometimes when you have a clinical suspicion of malaria, but if the peripheral smear has come negative, that time you might have to repeat the peripheral smear every 6 to 8 hours, so that you there is a chance of you picking the the plasmodium stages in the film. Okay, so another thing, next step for the diagnosis is the rapid diagnostic test. So in the rapid diagnostics test, these what do? They help in detecting the malarial antigens. Okay, they help in detecting malarial antigens and the asexual form and the from the sexual forms. Okay, also this is very helpful because it is quick and simple. Okay, out of the rapid diagnostic test, the optimal test and the LDH detection of parasite LDH are the best compared to the parasite F test. So the optimal test and detection of parasite LDH as the best. Okay, compared to what is the parasite test? So parasite test is what? Parasite F test. So over here there is detection of HRP2 antigen. HRP2 antigen of Plasmodium falciparum. Okay. So another test is the polymerase chain reaction, but these tests are very sensitive, but they are not available, and there is a lot of limitation for the practical utility, and that is why the severity of malaria is important. Okay, so that as I've told you in the previous slide, You know, as I've told you, the sugars you have to check. To check anemia, you have to get a complete blood count. You have to get an ABG to check for metabolic acidosis. You have to get a liver function test to check if there is any hepatic dysfunction. To check for renal impairment, you have to get a renal function test. Okay, but if a patient comes with shock, it is compulsory to the other drugs like quinine, pyrimethamine, sulfadoxine, okay, are not used in Vivax, okay, because they do not have any activity. Okay, so there are other drugs which can be used like the combination of artemether and lumefantrine, but there is high risk of relapse. Okay, there is a combination of artemether and lumefantrine, but there is high chance of relapse. Okay, and therefore the best drug of choice is chloroquine. Next, when if there is uncomplicated falciparum malaria, what do you do? If there is uncomplicated malaria, so if there is uncomplicated falciparum, the first thing is you should always go for combination therapy. Okay, okay, so if you go for combination therapy, it will reduce the risk of emergence of resistance. That's why combination therapy is gone for. So the combination therapy includes artemisinin based combinations, that is ACT. Okay, so basically in artemisinin there are various derivatives. One is artemether, one is artesunate, one is arteether. Okay, artemether, artesunate and arteether. Okay, so many, yeah, they have anti-malarial effect on from ring forms to the mature trophozoite. So this is a very good action. So it has an antimalarial effect on almost all the forms of the plasmodium. Okay, but while quinine has only the effect on the mature forms of the plasmodium. So quinine is okay. So now what is the best combination which is used for uncomplicated falciparum malaria? The best is the artemether and the lumefantrine. So artemether and lumefantrine is the best. So other combination includes mefloquine, pyrimethamine and sulfadoxine, then amodiaquine. These with combination of one of these, okay, combination with artesunate. So this is an other option. Or okay, so sometimes what happens, you can also give an oral quinine with clindamycin or doxycycline, or you can go for oral quinine with clindamycin or doxycycline. So these are the various combinations which are given for uncomplicated falciparum. The best one is the artemether and the lumefantrine. Okay, so and the chloroquine should not be used in falciparum malaria. First thing, unless it shows any sensitivity for chloroquine. Otherwise, chloroquine should not be given for falciparum malaria, and monotherapy should not be given. Okay, and in another very important thing you should remember is once the treatment with all these drugs is over, you have to give a single dose of primaquine. Okay, to have a this is a gametocidal dose, single gametocidal dose. Okay, this will help in the prevention of community transmission of malaria. Okay, so now if there is a mixed mixed malaria, what do you do? If there is Vivax and falciparum, then you go for the treatment same as for uncomplicated falciparum malaria. Okay, Okay, so still there is so much. Yeah, wait and see. Okay, so now when it comes to complicated malaria, what do you do? Complicated malaria. So when there is complicated malaria, as I've told you the criteria for severe malaria, right? So if any if this the treatment for Vivax or falciparum, if it is a complicated malaria, it is going to be the same. Okay, so first of all, you have to give supportive therapy, because these patients will might have anemia, they'll have shock, metabolic acidosis, so they have to be treated first with that. Okay, so next, what is the anti-malarial drug which you will use? So you will use artemisinin based therapy. So now I have told you artemether, arteether, artesunate are the artemisinin derivatives. So all these are, present in the parenteral formulations. So now, but when you go for artesunate, okay, so that is, you can give IV, but artemether and arteether, you give IM. Okay, so this is how. So once you start these this anti-malarial therapy, by 72 hours and by 5 to 6 hours, you will see the parasite count decreasing. Okay, and by 72 hours, so once this parasitemia disappears, then you should go for oral therapy. Okay, and also even in complicated malaria, once you finish the treatment, you have to give a single dose of primaquine. Following the treatment, should give a single dose of primaquine to prevent the transmission in the community. Okay, another very important, so the adverse effects with artemisinin based therapies are less, but sometimes if when you give a very high dose of artemether, there has been a chance of what is it, cardiotoxicity. So always remember not to give another drug which has cardiotoxic effects along with artemisinin based drugs. Okay, so that is that we need to keep in mind. So you can't give artesunate along with the quinine, right? Because quinine also has a cardiotoxic effect. So you have to see what combinations you give based so that the child doesn't have any cardiotoxic effect. Okay. So next, coming to quinine based therapy. So one came to know is, the first thing is artemisinin based therapy. So next is the quinine based therapy. Okay, so in the quinine based therapy, this parenteral quinine is in the form of dihydrochloride salt. Okay, so in quinine, what happens is, first you have to give a loading dose and then you give a maintenance dose. Okay, so here why do we give quinine as a loading dose? Because so that a therapeutic effect is maintained in the body. Okay, but you should always ask for a history, that if the child has already received quinine. So sometimes what happens, if the child is not getting treated, I mean getting better, they refer, right? So when the child is referred to another hospital, you should always ask if the child was receiving quinine. So if the child has already received quinine, do not give a loading dose of quinine. That can lead to quinine toxicity. Okay, so another thing is, you can give IM injections of quinine, but if you give subcutaneous, it can lead to necrosis. Okay, so now in quinine, how does a parasite count reduce? So in quinine, it takes 24 hours for the parasite count to reduce. Okay, and if the quinine is needed for more than 48 hours, so IV quinine is needed for more than 48 hours, then you have to reduce the dose. So what happens is, the maintenance dose of quinine is 10 mg per 10 mg salt per kg. So if the requirement of quinine is for more than 48 hours, you have to reduce it to 5 mg per salt per kg, so that the toxicity doesn't happen. So what is the second drug which we can use along with this quinine? So if you're using quinine, you can use pyrimethamine sulfadoxine, you can use clindamycin, or you can use doxycycline. Okay, after completion of this treatment, it is compulsory to give a single dose of primaquine. Okay, but only what are the contraindications for quinine is if there is G6PD deficiency and if there is a severe quinine allergy. So this is how. So contraindication for, yeah, so the contraindication is if there is severe quinine allergy or if there is G6PD deficiency. Okay, so this is for malaria. So today we finished so much about malaria. This is very good. Yeah, another thing, a very important thing, the vaccine. Okay, so in malaria, the vaccine has come. The vaccine which has been in trials is the name of the vaccine is RTSSASO1. This vaccine acts against falciparum malaria. Okay, so remember. Okay, now coming to leishmaniasis. So leishmaniasis is caused by the parasite by the genus Leishmania. Okay, so this is caused by the bite of female sandflies. Okay, so how do these present? So there are three major clinical forms. So one is the visceral leishmaniasis. Visceral leishmaniasis. Next, there is cutaneous leishmaniasis. And then there is mucocutaneous leishmaniasis. Okay, so in India, the visceral and the cutaneous leishmaniasis is seen in India. Okay, and over here what happened, there is a lot of cases in India being reported. Around 2 lakh cases of leishmaniasis gets reported in India, and most commonly they are seen in Bihar and eastern UP. Okay, okay, this is how leishmaniasis this is the what is it, overall epidemiology. So coming to the transmission of leishmaniasis. So this leishmaniasis in the humans or any other animal reservoir, it is in the amastigote form. Amastigote form. Okay, this amastigote form is non-flagellated. Okay, these are oval. Okay, they are oval round bodies of Leishmania donovani, but they don't have flagella. So amastigote, they don't have flagella. But in the sandfly, they are promastigotes. That is, they are flagellated. Okay, so now what happens? So this female sandfly, now the sandfly will ingest the amastigotes from the human, right? The female will ingest the amastigotes from the humans. Now in the digestive system, this amastigote will become promastigote. Okay, so it will become promastigote. So this promastigote goes to the salivary glands and then it is injected into the humans. Okay, so the promastigote goes to the salivary gland and then it is injected into the humans. So now what does it do? So once it enters the humans, okay, the promastigote will causes phagocyte. It gets phagocytized by the macrophages. Then the promastigote transforms into amastigote inside the macrophages. Then this multiplied inside the macrophage and they get released. Okay, so this is the transmission. So basically they work in they are present in the macrophage system. Okay, so macrophage system, and then they enter all these reticular endothelial cells. So whatever is required for the immunity of the patient, so the innate immunity is caused by the macrophages, right? So these will affect the innate immunity of the human being once they get affected. So this is more commonly seen in children between 1 to 4 years. 1 to 4 years. Okay, and the protective response is generally cell mediated immunity, but you can see there is yeah, but the immunity also gets. So first we go to the visceral leishmaniasis. Okay, so the incubation period for visceral leishmaniasis is between 3 to 8 months. Okay, so here these patients will present with high grade fever, weight loss, and splenohepatomegaly. What does splenohepatomegaly mean? The spleen is more enlarged, right? The spleen is more enlarged compared to the liver. So in a child with visceral leishmaniasis, splenomegaly will be present, and in around 10% cases, 80% cases, there will be hepatomegaly. Okay, so in Indian visceral leishmaniasis, there is hyperpigmentation. Okay, and there will be progressive emaciation. Some of them will present with cough and diarrhea. Okay, also if there is bleeding manifestations happening, there will be epistaxis. Okay, there will be petechial hemorrhages, there is gum bleeding happening. Okay, so this is how they'll present, and sometimes they might present with pedal edema, that is because of hypoalbuminemia. Jaundice also may be present. These are all rare presentation. Okay, now there is decreased cell mediated immunity here. That is why there are chances of high secondary infections. Okay, and when you get a blood test, there is pancytopenia, and also there is hypergammaglobulinemia. Okay, that is characteristic of leishmaniasis. Okay, so now how these generally present very insidiously, and they'll be initially asymptomatic, and there will be a chronic course. Okay, that may be fatal. It may be fatal sometimes, with or without treatment. So sometimes if there is no treatment, it might go to mortality. Otherwise it might reduce on its own. It will be spontaneous. Okay, so sometimes if there is death, it's because of severe bacterial infection. Death is because of severe bacterial infection or GI bleed in advanced diseases. Okay, so this is how visceral leishmaniasis presents. There is something called as post Kala Azar dermal leishmaniasis. Okay, so here what happens, it is following the visceral leishmaniasis, maybe after 10 years or after a long period, you can see hypopigmentation happening. Hypopigmentation, remember, in visceral leishmaniasis there was hyperpigmentation, but in post Kala Azar dermal leishmaniasis there is hypopigmentation. Okay, so there could be hypopigmented macular or maculopapular or nodular skin lesions. Okay, so first they present in the perioral region, then it goes to the chins, it goes to the lips. Okay, then it goes to the neck, then the extensor part of the legs and the extremities. So this is how this hypopigmentation presents. So first it presents at the perioral region. Okay, now the scalp, palms and the soles are spared, but the rest of the entire body might get affected. So the best differential diagnosis for post Kala Azar dermal leishmaniasis is lepromatous leprosy. But what happens, how do you differentiate? The peripheral nerves are spared. Okay, in leprosy what happens, there is neuritis, peripheral neuritis, right? So here the peripheral nerves are spared. Okay, and these will act as a chronic reservoir, or these patients will act as chronic reservoir for the infection, for leishmania. Fine. So now how do you diagnose? So as I've told you, when you get a blood test done, there is pancytopenia, right? So there is pancytopenia, there is hypergammaglobulinemia. Okay, so this is very important. Then how do you definitive diagnosis? That is by microscopic detection of amastigotes. Okay, when you do a micro detection of amastigotes. Okay, so the best possible what is it specimen for diagnosing is the bone marrow, because you, as you all know, it affects the endoreticular system. So the bone marrow specimen is best for the microscopic study of the study for leishmania. Okay, so another tests are other tests which are which help in the diagnosis of leishmania are chromatographic, strip, and ELISA. That is for the leishmanial anti-K39 antibody. Okay, so now what happens? The problem with this is this disease is seen in more of an endemic area. So what happens is the antibiotic titers decrease after a successful, but it will suddenly increase to relapse. So now we won't. So only thing is it helps us to recognize if there is treatment failure. So this helps in the recognition of treatment failure. So there are newer methods. There are newer methods which have been used. They are for the detection of the leishmania antigen and the antibody in the urine. Okay. So now coming to the treatment. So the most commonly used drug is sodium sibogluconate. This is the drug which is used. So the other drugs which are used are amphotericin B and miltefosine. Okay, the first line of drug is always sodium stibogluconate. But now with the National Vector Bone Disease Control Program has told, if there is resistance to sodium stibogluconate by more than 10%, then you go for amphotericin B. Okay, so also the miltefosine is another very active drug, active agent. So the treatment of this drug will go for 3 to 4 weeks. Okay, and other effective drugs which are these three are the most important, right? So the other drugs which could be used are pentamidine and paromomycin. Okay, so these are the drugs which are used. Okay, so how do you know the child has responded? So first thing is the fever, spleen size, and the hemoglobin and the body weight will improve. Okay, this will be seen in first the fever subsides. Once the fever subsides in 7 days, you will see the improvement in hemoglobin. Okay, so but if how do you know there is relapse? So again, the relapse, there will be increase in the spleen size and there will be fall in hemoglobin. Okay, the spleen will actually take 1 to 2 years to decrease to the normal size. So you have to regularly check for the size. But when you're checking for the size of the spleen on follow-ups, and if there is increase in the size, that means the patient would have been in relapse. Okay, so this is how you check. So you how do you prevent? So main thing is preventing the transmission, eradicating the vector. That is the sandfly. That is the main way. How do you control the source? Okay. So now coming to amoebiasis. So the amoebiasis. So amoebiasis is caused by Entamoeba histolytica, right? Okay. So now how does this Entamoeba histolytica cause infection? First, it exists both as cyst, okay, or the trophozoite phase, trophozoite stage in the nature. Okay, so now what happens? The cyst, when it is ingested, it will exist in the small intestine. Okay, so once it exists in the small intestine, this will produce around 8 trophozoites. Okay, and these trophozoites will colonize in the mucosa of large intestine. Right, so now these trophozoites may have tissue, they cause tissue invasion. These trophozoites will cause tissue invasion. They will destroy the other destroy through several other virulence factors. So that is why, because they cause tissue destruction, right? That is why they cause flask shaped ulcers. So these flask shaped ulcers are commonly seen in the cecum, in the transverse colon, and the sigmoid colon. Okay, so what are the extraintestinal complications? So the in the extraintestinal complications could be extraintestinal. They might migrate to the bloodstream, and they might go to the portal circulation. Okay, and they can affect the liver. So they'll enter the bloodstream, they might enter the portal circulation, and they might affect the liver. This is how the extraintestinal manifestation of amoebiasis is. So the amoebic abscess, amoebic liver abscess, another presentation of amoebiasis, right? So what is the clinical features? Okay, so so main thing is there will be dysentery. So these children can present with loose stools. Okay, so the incubation period can vary from weeks to months. Okay, so when it is symptomatic, so most of the time they're asymptomatic. So when they're symptomatic, they can present as amoebic colitis. Okay, so there is severe abdominal pain, or there is severe tenderness. There could be watery or bloody loose stools, or mucus stool, loose stool. Okay, so there will be pain or tenderness. Okay, there could be loose stools, could be watery, bloody, or with mucus. Okay, again, very important thing is fever is not very common. Okay, sometimes they might present with fulminant amoebic colitis. So over here what happens, there will be profuse bloody diarrhea. Okay, there will be bloody diarrhea, there will be fever also over here, and then there is leukocytosis. So this is how. And as what are the complications when there is an intestinal amoebiasis? What could be the complications? So complications of intestinal amoebiasis includes, one is toxic megacolon. Okay, there could be amoeboma. Okay, there could be cutaneous amoebiasis, and there could be rectovaginal fistula. Amoebiasis actually is not very common in children. It is more of a adolescent or an adult disease. Okay, okay. Then now, if there is amoebic liver abscess, how will the child present? If there is amoebic liver abscess, how will the child present? Okay, so 1% of the children who are affected with intestinal or with amoebiasis, they might go for amoebic liver abscess. Only 1%. Okay, so they could present with fevers with chills and rigor, and there will be severe upper right quadrant tenderness and pain. Okay, so now if there is an amoebic liver abscess, what are the complications? So complications is they could rupture to the pleural space, they could rupture to the pericardial space, right? So rupturing to the pleural space has a good prognosis, but if it ruptures to the pericardium, or if there is super infection with the bacteria, has very serious prognosis. Okay, so they could rupture to the pleural space or the pericardium. Okay, so rupturing to the pleural space has a good prognosis. If the liver abscess ruptures to the pericardium or there is a secondary bacterial infection, prognosis is very bad. Okay, so now coming to the diagnosis. So now the diagnosis is by demonstrating the motile trophozoites. Trophozoites. So you should be able to demonstrate the trophozoites. Okay, so that is how you diagnose. So a fresh sample is required. Sometimes what happens, you might need at least 3 fresh samples to demonstrate, because it has poor sensitivity. Demonstrating the trophozoite has poor sensitivity, so that might need at least 3 stool samples. Okay, so in the amoebic stool sample, there will be a lot of erythrocytes, but that might be not much of a leukocyte. Okay, there will be few leukocytes, but when you see bacillary dysentery, the leukocytes are more. Okay, so what are the serological tests? So because serological tests are very important, because you have to differentiate this from a pyogenic liver abscess or a amoebic liver abscess. So one, you get an ELISA, then you can get indirect hemagglutination assay, then you can get indirect fluorescence assay. Okay, so these will help in the diagnosis of amoebic liver abscess. So the only, so that we can differentiate between the pyogenic and the amoebic liver abscess. So uh, when there is a liver abscess, you have to get a radiograph, so that you can see there is any elevation of the diaphragm. Okay, and there is any pleural reaction on the right side. Ultrasound, CT or an MRI is need to localize the abscess. Okay, so radiology. So what is the treatment? So what is the treatment? So for the first anti-amoebic treatment, what we give is metronidazole. Okay, this is the drug of choice. Okay, so the next other alternatives are tinidazole. Okay, there could be secnidazole or ornitazole. So now this metronidazole cannot destroy cysts, so it needs a luminal agent. Okay, so along with this, you have to give a luminal agent, that is the diloxanide furovate. Okay, so this will eradicate colonization. So this will eradicate colonization. So now what happens, this is for intestinal, right? So in case of liver abscess, so in case of liver abscess, you can manage just with metronidazole. Okay, so even if it is large, you can just manage with metronidazole. So along with that, you should give diloxanide. Okay, so this will help in preventing intestinal colonization. So when do we do the drainage? So aspiration is reserved. Okay, aspiration of this amoebic abscess is liver abscess is reserved. So it is done when there is uh, when you're not sure, if it could be a pyogenic infection. Another thing is when it does not respond to, so aspiration when there is no response to metronidazole. Okay, when the abscess is more towards the left. Okay, it is a left lobe abscess. Why left lobe abscess we are scared of? Because this can cause rupture to the pericardium, and rupturing to the pericardium is a serious prognosis, right? Okay, and if the size is more than 8 to 10, if the size is more than the liver abscess, the size is more than 8 to 10 centimeters, this also can rupture. Severely ill patients, okay, whose clinical condition is deteriorating, okay, and because of the large abscess. So in such patients you do the aspiration, so you aspirate and then you do a percutaneous catheter is put so that it drains out well. Okay, so this improves the outcome in the treatment of amoebic empyema with liver abscess. Okay, so if there is amoebic empyema, you drain and then put the this thing, what is it, drainage. So this is how you manage. So in case of amoebic pericarditis, the drainage is a life-saving this thing, treatment. So now coming to giardiasis, today's last topic. So you know giardiasis is caused by Giardia lamblia, right? So this is very common. This is a prominent cause of loose stools in children. Prominent cause of loose stool. So now what happens? Children who are only who are given only breast milk, fed with breast milk, they have a protection against a giardia. Okay, because the giardiasis has protection by from the secretory IgA. Okay, so if the child has malnutrition, or there is humoral immunodeficiency, okay, or if there is other conditions which cause immunosuppression, they are highly susceptible to giardiasis. So now when coming to the etiopathogenesis, the giardia is present both as a cyst and trophozoite. Okay, so now outside the body, this cyst can be present at any cold temperature. Okay, so the cyst is what is it, destroyed by boiling. The cyst is destroyed by boiling. So it can survive in the outside environment at any cold temperature. Okay, so if you boiling helps in destroying the cyst. Okay, so now how does it get transmitted? So when there is an ingestion of any contaminated food, okay, so the cyst gets transmitted. Okay, so around 10 to 100 cysts are enough to cause the infection, right? So once they go to the duodenum. Okay, they go to the duodenum, and then there they cause cyst. So the cyst comes out. So when they exist, they'll release trophozoites. Okay, so now this trophozoite will go to the duodenum and the proximal jejunum. Okay, and then they'll attach to the intestinal brush border. Okay, but when compared to amoebiasis, these in case of giardiasis, they don't do deep destructions. Okay, so the ulcers don't happen, but they cause diarrhea, and then there will be intestinal malabsorption. So feature of giardiasis is intestinal malabsorption. Okay, and as a result they can cause chronic and enteritic disorders like acute inflammatory disease. They can cause irritable bowel disease. Then if the pancreas are involved, there could be steatorrhea. Okay, then there will be bacterial overgrowth also. So now what is the incubation period? So the incubation period is 1 to 2 weeks. So most of these infections are asymptomatic, but if they become symptomatic, okay, they're present with diarrhea. Okay, so there is sudden explosive watery diarrhea. Okay, there is that is how they present, and there is foul smelling diarrhea. Okay, then there could be epigastric cramp. There is no blood or mucus in this. Okay, so this is how they present, and the main thing is there will be various forms of malabsorption. How do you diagnose? So diagnose is by microscopic examination. So you will have to take 3 fresh samples on alternate days to check for the cysts or the trophozoites. Okay, so microscopic demonstration. So other tests include the enzyme immunoassay. So enzyme immunoassay and the direct fluorescent antibody test. Okay, so antibody assay. So these help in the detection of the giardia antigens. So enzyme immunoassay and direct fluorescent antigen test so helps in the detection of Giardia antigen. So how do you treat? So treatment is again by metronidazole. Okay, the treatment over here is metronidazole. So even for amoebiasis, it was metronidazole, right? So metronidazole. The other options are tinidazole. Okay, and next one is the nitazoxanide. The second line of drugs is albendazole, paromycin. Okay. Okay, so this is how the giardiasis presents, right? So this is for today's, so we have completed today's class. So now we'll do a fast brush up so that you remember. So as I've told you, malaria is because of the genus Plasmodium. So there are 4 types of species: Vivax, Plasmodium, ovale, and Malariae. So the infectious stage is sporocyte. So the sporocyte gets transferred to the humans by the bite of the Anopheles mosquito. So in the human body, there are 4 phases of the life cycle of the this Plasmodium. So in the hepatic phase, what happens? The sporozoites are released and it infects the hepatocytes. From the hepatocytes, there is multiplications happening, and that will lead to the release of merozoites. So the merozoites, they enter the erythrocytes and they'll bind to the erythrocyte. There, what happens? They form first the immature trophozoites, or the early trophozoites, or the ring forms of trophozoites, and then lead to form the mature trophozoites. So once the mature trophozoites are formed, there will be multinucleated schizoid which are formed. So again, the multinuclear strand which will rupture and the merozoites will be released to the blood circulation, and then there is a cycle of these merozoites infecting the erythrocytes, right? And and another thing is, in this phase, what happens is the falciparum has a cytoadherence effect, and as a result, relapse with falciparum is less. But with Vivax, ovale, and malaria, the relapse rates are very high. Okay. Now, the clinical features, what we see is the incubation period is between 9 to 30. So the 9 to 30 days. The least incubation period is for uh, falciparum, and maximum is for malaria. Okay. So in malaria, the fever is divided into cold stage, hot stage, and sweating stage. First, there will be chills and rigors, and in the hot stage, there will be dry, flushed skin, right? And there is an increased thirst. In the sweating phase, the following which the child will have severe sweats. So the in malaria is divided into complicated and uncomplicated malaria. Okay, so complicated malaria is diagnosed with the following criteria. Okay. So how do you diagnose? The first best diagnosis is examining a thick film. So in a thick film, you can get 5 to 10 parasites per microliter can be checked for. But in a thin film, you should do species identification. Helps in species identification. So this film, in the because with the help of the peripheral smear, you are able to check for the parasite load, the prognosis. So if there is a mature schizont or a pigmented neutrophil, the prognosis is bad, and it helps to track the response of the therapy. So rapid diagnostic test, there is optimal test, then there is detection of parasite LDH, and there is parasite F test. Okay, other tests are the polymerase chain reaction, and blood culture should be sent if there is a child who presents with shock. Okay, if there is an uncomplicated malaria, the drug of choice is chloroquine. So once, along with chloroquine, you should give primaquine for 14 days. Okay, because the primaquine has a schizonticidal effect. Next, other drugs are combination of artemether and lumefantrine, but there is high chance of relapse. In uncomplicated falciparum malaria, you give a combination therapy. So always a combination therapy is best, so that you prevent the chance of resistance. So artemisinin based combination therapy are used. They have a very good anti-malarial effect. So they have effect on the ring forms as well as the mature trophozoite, while the quinine has effect only on the mature forms of the plasmodium. So the primaquine is given as a single dose as a gametocidal dose. Quinine, so forget quinine. Okay, so the best combination drug is the artemether and the lumefantrine. Or other alternatives are, if you can give mefloquine with artesunate, or you can give pyrimethamine sulfadoxine with artesunate, you can give amodiaquine with artesunate, or you can go for quinine with clindamycin or doxycycline. So that should be done for a child above 8 years. Okay. Next, if there is a complicated malaria, there is the treatment doesn't differ for falciparum and vivax. The treatment is going to be the same. First is going to be a supportive treatment. So any complication because of malaria should be treated. Along with it, the patient should be treated with artemisinin based therapies. So artesunate can be the treatment will be parenteral. Okay, so RT Sunate will be IV, RT meter or RT ether will be IM. Okay. So once you start with this therapy, within 5 to 6 hours, the parasite load comes down. And by 72 hours, the asexual parasitemia disappears. And following which you go for oral therapy. Okay. So once the course of RT drugs are done, then you have to go for a single dose of primaquine because that has a gametocidal effect and that will prevent the community transmission of the malaria. Okay, so the next option for complicated malaria is quinine based therapy. So the drug which is used for the parenteral the quinine component which is used for the parenteral therapy is dihydrochloride salt of quinine. Okay, so here once you start quinine therapy, it needs 24 hours for the parasite count to come down. Okay. Next, once you complete the course of quinine, you have to give a single dose of primaquine again because it is a gametocidal effect. So the vaccine which is used which is under trial is called the RTS AS01. This is against the falciparum malaria. Now coming to leishmaniasis. So the leishmaniasis is caused by Leishmania donovani. So there are three major types of clinical presentation. One is visceral leishmaniasis, then there's cutaneous leishmaniasis and mucocutaneous leishmaniasis. The visceral and the cutaneous are seen in India and more commonly in Bihar and eastern UP. Okay, so first in the humans, it is as a human reservoir, the leishmania is present as amasticode form. That means there is no flagella. While in the sandfly there is promasticode form, and that is how it gets injected into the humans. So how are the clinical features of visceral leishmaniasis? So the incubation period can vary from 3 to 8 months. They might present with high grade fever and weight loss. So and the main important thing you need to know is there is splenohepatomegaly. Okay, the spleen is more enlarged when compared to the liver. Okay, then in some of the patients they might have hyperpigmentation. They might also have bleeding with the epistaxis, gum bleed. They can have petechial hemorrhages. Okay, and as these patients have decreased cell mediated immunity, so I've told you the promastigodes, they affect the macrophages, right? So there is decreased cell mediated immunity, and as a result there could be increased cell infection. So in these patients, if there is death, it is because of severe bacterial infection or because of increased gastrointestinal bleed during the advanced disease. Okay, so something called as post-Kala-Azar dermal leishmaniasis is there. So this develops quite a long time after the visceral leishmaniasis is also treated. So here what happens, the patients may present with pigmentation. There could be macules, maculopapular lesions, or it could be nodular lesions, but there will be hypopigmentation. First it happens in the perioral region and then it spreads to the other part of the body. The scalp, palms and the soles are spared. So the main differential diagnosis is lepromatous leprosy, and but in post-Kala-Azar dermal leishmaniasis, the peripheral nerves, the nerve sensations are spared. So that is how you differentiate lepromatous leprosy. Okay, and these patients who have post-Kala-Azar dermal leishmaniasis, they're chronic reservoirs of leishmania. Okay. So another very important thing you need to know is when you get a blood test and there is pancytopenia and hypergammaglobinema. Okay, and the definitive diagnosis for leishmania is microscopic detection of amastigotes. Okay, and the treatment is, the first treatment of choice is sodium stibogluconate, and there is amphotericin B and there is miltefosine. Okay, the other drugs are pentamidine and paromomycin. In amoebiasis, the amoebiasis is caused by Entamoeba histolytica. So there could be intestinal and extraintestinal presentation. So in intestinal presentation, it could be as amoebic colitis or fulminant amoebic colitis. So these this Entamoeba histolytica has a destructive property in the intestine and can cause flask-shaped ulcers. Okay, but the extraintestinal amoebiasis will present as a amoebic liver abscess. Okay. So diagnosis is by demonstrating the motile trophozoites. Okay, that is the best diagnosis. And the treatment is metronidazole. Other alternatives are tinidazole, secnidazole, or ornitazole. But along with metronidazole or the other alternatives, you have to give luminal agents like diloxanide, furovate, because it has an action against the cyst. Metronidazole has no action against the cyst, and that is why it can help in eradicating colonization. When you as a treatment for liver abscess also, though along with metronidazole you have to give diloxanide, because it will help in preventing intestinal colonization. Okay, so but if there is no response to metronidazole, or if there is a left lobe abscess which can cause rupture to the pericardium, or if there is a large liver abscess which is of 8 to 10 centimeters, or if the patient is very ill and the clinical condition is deteriorating, then you should go for aspiration of the amoebic liver abscess. So next, coming to giardiasis. So giardia is caused by Giardia lamblia, and this is a very prominent cause of loose stool in children. So giardia can be present in both the cyst and trophozoite outside in the nature. Okay, so this is the cyst enters our body through the ingestion of contaminated food. There are around 10 to 100 cysts are enough to cause an infection. So first they go to the duodenum, and into the duodenum the cysts encyst and cause the release of trophozoites. Okay, and this goes to the intestinal brush border and can cause intestinal malabsorption. Okay, so the incubation period is 1 to 2 weeks. The symptom is diarrhea, so there is explosive sudden onset of diarrhea in these children, and but there is no blood or mucus. Okay, the diagnosis, and another important thing is they can present with malabsorption. Okay, so the main diagnosis is by microscopic demonstration, and other important diagnosis test is by the enzyme immunoassay or the direct fluorescent antigen test. So this helps in detection of the giardia antigen. The treatment is by metronidazole, tinidazole, and nitazoxanide. Okay, the other option is the albendazole or parmomycin. So remember this. So this is for today's class. So we have completed all the protozoal infections. So next, tomorrow we'll be discussing on tuberculosis. Following which the next class will be on congenital infections or the perinatal infection, and following which there will be quiz on infections. So all the infections I'm going to give a quiz, and I'm not going to have much of a discussion. This is just going to be questions and answers, and very important topics I will have a discussion. Okay, so the quiz will be on Saturday. Fine. So tomorrow I'll be starting a neonatology class. So tomorrow's first class in the subscription platform, the first class will be on the introduction to neonatology. So all the basic important definitions of a normal newborn will be taught, and a high risk infant will be taught, and the neonatal reflexes will be taught tomorrow. So it will be a 90-minute class, and it will be at 4 o'clock tomorrow at the subscription. Okay, all the best, study well, discuss with your study partners, and that will help you a lot in your revision. Okay, so use my code Shilpa10 if you're subscribing to the subscription and get a 10% discount. Okay, good luck.